talk about lumbosacral plexopathy and sciatic neuropathy. And I'm very lucky to introduce this lecture after my Professor Dr. Ann lecture about brachial plexopathy, and this lecture considered complementary to the Dr. Ann lecture. Lumbosacral plexus is a complex structure in the pelvis. It provides nerve supply to the pelvis and lower limb. In addition to part of the autonomic supply to the pelvic viscera, it's formed from the anterior rami of roots from L1 to S3, from which all major lower extremity nerves are derived. Anatomically, usually it's divided into two parts, upper lumbar and lower sacral plexus. The upper lumbar plexus, it's formed from the ventral rami of L1, 2, 3, and L4. It's located in the retroperitoneum behind the psoas muscle. Main branches is the iliohypogastric and ilioinguinal, both derived from L1. And gives motor branches to the transverse and internal oblique muscles, and gives ilioinguinal nerve gives sensation to the anterior thigh, upper scrotum in males, and labia majora in females. The genitofemoral nerve derived from L1 and L2 and gives two branches, which is genital and femoral branches. The genital branch give muscular innervation to the cremasteric muscle and the skin over the lower scrotum in males and labia majora in females. The femoral branch gives sensation to the skin over the femoral triangle. The fourth branch is the lateral cutaneous nerve of thigh. It's derived from posterior division of L2 and 3. It's purely sensory nerve. It emerges from the lateral side of psoas muscle and crosses obliquely towards the anterior superior iliac spine, and then pass under the inguinal ligament in this place where it's supposed may be compressed in this side. It gives sensation to the lateral aspect of thigh. Compression of the nerve or lesion to this nerve at the site of the inguinal ligament gives a condition which is called meralgia parathetica. Causes of meralgia parathetica can be caused by external compression over the nerve, like in a seat belt or tight abdominal waistband, or due to surgery, like in inguinal hernia repair. Obesity also can predispose to this condition, and pregnancy. The patient complaining from sensory loss or paresthesia or pain over the lateral thigh, which is exacerbated by leg extension and prolonged standing. How it is diagnosed? By doing the nerve conduction study of the lateral cutaneous nerve of the thigh. We stimulate the nerve at just medial or 1 centimeter medial to the anterior superior iliac spine, and record over the lateral thigh 12 centimeter distal to the anterior superior iliac spine in a line drawn between the anterior superior iliac spine and lateral patella. If we couldn't obtain response in this site of stimulation, we could move the stimulator either medially or laterally to the anterior superior iliac spine, as there is a normal variation in the course of the nerve in normal individuals. It's technically difficult to obtain this nerve, as especially in obese patient. Also, it may be absent in normal individuals. So it's advisable to do the normal side first, as if it is absent, most probably the affected side also will be absent, so we can't compare to the other side. It's a small amplitude response and needed to be averaged. Also, as I mentioned, it must be compared to the other side to know the percent of axonal loss. If the amplitude is less than 50% of the normal side, so it's affected. The fifth nerve is the obturator nerve derived from the anterior division of L2, 3, and 4. It exits from the medial side of psoas muscle and it enters the thigh through obturator foramen. Its supply motor branches to the adductor muscles of the thigh, which is the adductor brevis, adductor magnus, adductor longus, and gracilis. And it gives sensation to the upper part of medial thigh, small area of the upper medial thigh. So its injury leads to weakness of thigh adduction and internal rotation, and loss of sensation over a small part of the upper thigh. And the largest branch, which is the femoral nerve, which is derived from the posterior division of L2, 3, and 4. It exits from the lateral side of psoas muscle and it enters the thigh behind the inguinal ligament, just lateral to the femoral artery. It supplies muscular branch to the iliacus and psoas muscle in the abdomen. Then it descends in the inguinal region where it divides into two branches, the anterior division and posterior division. The anterior division gives a muscular branch to pectineus and sartorius muscle and gives sensation to the anteromedial part of the thigh through medial and intermediate cutaneous nerves. And the posterior division supply the foreheads of the quadriceps muscle and continue as a saphenous nerve. So injury of the femoral nerve will lead to weakness of hip flexion, loss of knee extension, and sensory loss over the anteromedial thigh, knee, leg, and medial foot. How it is diagnosed? By doing nerve conduction study of the femoral nerve. We stimulate below the inguinal ligament, just lateral to pulsation of the femoral artery, and record over the rectus femoris, over the anterior thigh, midway between the site of stimulation and the knee. But it's technically difficult also, especially in obese patient. We have to press the stimulator firmly and we have to increase the stimulus intensity, stimulus duration to obtain nerve conduction response. Its amplitude most probably 3 millivolt, but we need to compare to the other unaffected side also. Its abnormality may localize the lesion at the femoral neuropathy or more proximal part as lumbar plexopathy or in cases of L4 radiculopathy. The saphenous nerve, which is a continuation of the femoral nerve and the largest cutaneous branch of the femoral nerve, supply sensory to the medial leg, knee joint, medial leg, and medial foot. So its injury leads to loss of sensation over these areas or may lead to severe neuropathic pain in these areas. How to diagnose? By doing nerve conduction study of the saphenous nerve. It's also technically difficult to be obtained and may be absent in normal persons, especially in age above 40. We record midway between the medial malleolus and tibialis anterior tendon, and stimulate about 14 centimeters above the site of recording between the medial gastrocnemius and tibia. It's usually of a small amplitude response, maybe about 4 microvolts, so it's needed to be compared to the other unaffected side to obtain pathology. So lesion of the upper lumbar plexus will mainly affect L2, 3, and 4. And in this situation, the weakness will be concise to the quadriceps, iliopsoas, and hip adductors muscles, with sensory loss over the lateral, anteromedial thigh, and medial cuff. With pain in the pelvis, in the anterior thigh compartment, and the knee reflex is reduced or completely absent. Then the sacral plexus, it's formed from the anterior primary rami of roots from S1 to S4, with a contribution of a lumbosacral trunk derived from L4 and 5. It's situated on the anterior surface of the piriformis muscles, and the main branches is superior gluteal nerve derived from L4, 5, and S1, which gives innervation to gluteus medius, minimus, and tensor fasciae lata. Inferior gluteal nerve derived from L5, S1, and S2, which innervates gluteus maximus muscle. The third nerve is a posterior cutaneous nerve of thigh, derived from S1, S2, and S3. It gives sensation to the buttock, genitalia, and posterior thigh. Pudendal nerve derived from S2, S3, and S4, and gives sensation to the genitalia, perineum, and anus. And the thickest and largest nerve in the body, which is a sciatic nerve, derived from all roots of the lumbosacral plexus. It leaves the pelvis through greater sciatic foramen, emerges below the piriformis muscle, and passes in the gluteal region between two bony landmarks, which is ischial tuberosity and the greater trochanter. Then it passes to the posterior compartment of thigh, undercovered by the gluteus maximus muscle. It's formed of two parts, the medial tibial part and the lateral perineal part. It runs down in the back of thigh till the upper angle of popliteal fossa, where it's divided into two terminal branches, the tibial and peroneal. What the muscle supplied by sciatic nerve? It supply semimembranosus, semitendinosus, ischial part of adductor magnus, and long head of biceps derived from the tibial part of the sciatic nerve, and short head of biceps supplied by the peroneal part of the sciatic nerve. It's the only muscle supplied by the peroneal nerve above the popliteal fossa, and it implies an important value in electrophysiological diagnosis in differentiating between common peroneal affection and sciatic nerve affection. Also, it supplies all leg and foot muscles and gives sensation to below knee, except the medial part, which is supplied by the saphenous nerve. So sciatic injury will lead to weakness of knee flexion, loss of all movement of leg and foot, loss of sensation below knee, except the medial part, and ankle reflex is reduced or absent. So the termination of sciatic nerve, as I mentioned, into two parts, the tibial part. Tibial part, as I mentioned before, it supplies hamstring muscles, except the short head of biceps in the thigh. Then it descends through the popliteal fossa and gives the sural nerve, and complete in the posterior compartment of leg, accompanied by the posterior tibial vessels, where it supplies the gastrocnemius, soleus, tibialis posterior, flexor digitorum longus, and flexor hallucis longus. Then it passes deep to the flexor retinaculum behind the medial malleolus to sole of foot, where it divides into two terminal branches, which is medial plantar, supply abductor hallucis, flexor digitorum brevis, flexor hallucis brevis, and gives sensation to the medial sole and first to third toes. And the other branch is the lateral plantar nerve, which supply abductor digiti quinti, flexor digiti quinti, adductor hallucis, interossei, and sensation to the lateral sole and fourth and fifth toes. The second part is the common peroneal nerve. It gives only the short head of biceps above the neck of the fibula, and then it leaves the popliteal fossa, where it gives a small branch to sural nerve. Then it turns around the lateral fibular neck, where it is suspected to compression or injury at this site. Then it divides into two terminal branches, the superficial peroneal, which descend into the lateral compartment of leg and gives supply to peroneus longus and brevis muscles and gives sensation to lower 2/3 of leg and dorsum of foot. And the other terminal branch is the deep peroneal nerve, which gives supply to tibialis anterior, extensor hallucis longus, peroneus tertius, extensor term brevis, and sensation to first whip space. Sciatic neuropathy. Causes of sciatic neuropathy in hip surgery, like in surgery of total hip replacement. Some studies found that 1 to 3% of patients describe immediate post-operative sciatic neuropathy due to stretch injury of the sciatic nerve during the operation. Trauma like in wrong place of intramuscular injection or repeated injection may lead to fibrosis and trauma to the nerve. Also, hip fracture and posterior dislocation of the hip may injure the nerve, and femur fracture and dislocation may also predispose to sciatic neuropathy. Open injury like in gunshot or penetrating injury can cause sciatic neuropathy. Compression by the piriformis muscle due to the close relation between the sciatic nerve and the piriformis muscle, as it passes just under the piriformis muscle or may penetrate the muscle itself. So hypertrophy of the piriformis muscle may compress the nerve in a condition called piriformis syndrome. Also could be compressed due to hematomas. Tumors like neurofibroma, schwannoma, and neurofibrosarcoma, or maybe due to infection and inflammation of the sacroiliac joint or due to presence of abscess or endometriosis. Sciatic neuropathy in general is uncommon and comes second after common peroneal neuropathy in a lower limb. It's presented by foot drop and pain over buttocks or may radiate to down the leg and posterolateral limb and leg. In more severe cases, patient may experience weakness in knee flexion and plantar flexion. So the important question, why sciatic neuropathy is presented by foot drop as if it is a peroneal neuropathy? Because the peroneal fibers are more vulnerable to compression than tibial fibers. One of the reasons that is the peroneal fibers contain lesser and larger fascicles than tibial part, and so more vulnerable to compression in sciatic neuropathy and leads to foot drop. What's the electrophysiological protocol for sciatic neuropathy? We will do motor nerve conduction study of both peroneal and tibial nerve and search for reduction of amplitude and do it bilaterally to compare to the normal unaffected side. We will do also F wave from peroneal and tibial nerve, and we'll do H reflex. The finding will be either prolonged waves or absent. Sensory in the form of superficial peroneal and sural nerve conduction study. Also, we will find either reduced amplitude or absent responses, and it's advisable to compare to the unaffected side. EMG, we will find signs of denervation in the form of FIPS or positive sharp waves, and signs of re-innervation in the form of prolonged large polyphasic motor potentials. in peroneal innervated muscles in almost all of the patients, and in tibial innervated muscles in up to 84% of the patient, and in thigh muscles supplied by the sciatic nerve according to the site of sciatic affection. We also have to exclude plexus affection by examining muscles of same root but with different nerve supply, like examining the gluteus medius and maximus muscle. We also have to exclude root affection like L5 and S1 radiculopathy by doing the paraspinal muscles. And we have to exclude peripheral neuropathy by comparing distal and proximal muscles and search for proximal to distal gradient abnormality pattern. If the sciatic neuropathy is presented by foot drop and peroneal nerve neuropathy also presented by foot drop, so we have to know what is the differential diagnosis of foot drop. If patient coming to our clinic presented by foot drop, so many levels of injuries could cause this condition, starting from the deep peroneal nerve to L4-5 roots affection. How to differentiate? By doing nerve conduction study and EMG. If it is confined, concise to the deep peroneal nerve only, so the superficial peroneal snap will be normal. EMG affection will be only for the tibialis anterior muscle, and peronei will be preserved, and tibial innervated muscles will be preserved also. If it is due to common peroneal nerve affection, entrapment at the fibular neck or so the tibialis anterior and peronei will be affected, but the tibial innervated muscles will be spared. If it is at the sciatic nerve level, the common peroneal will be affected and tibial innervated muscles will be affected, and also the proximal thigh muscles like hamstring also will be affected. If it is above the sciatic nerve, so other nerves will be affected if it is due to plexopathy, L4-5 plexopathy or lumbosacral trunk affection. So we examine other muscles supplied by same root but different nerve, like gluteus medius and gluteus maximus. If it is affected, so the injury is beyond the sciatic nerve, it's located mostly at the plexus level. And if it is at root level, so the paraspinal muscles will be affected and the sensory nerve conduction study will be spared. What is sciatica? It's a shooting pain along the course of sciatic nerve, starting in the buttock and radiate to posterior thigh, lateral leg, and dorsum of foot. It's caused by irritation of any root of the sciatic nerve by lumbar spinal stenosis or degenerative disc disease or in pregnant female. It's a shooting, burning, or stabbing pain starting from the buttock down the leg, with weakness, numbness, and difficulty moving leg in severe cases. What risk factors could predispose to sciatica? Age, as age changes concerning the spine, like in herniated disc is a common cause of sciatica. Obesity put stress over the spine and also predispose to spinal changes that would trigger sciatica. Some occupations which require bending of the back or lifting heavy object, sitting for prolonged time, like in driving motor vehicle or sedentary lifestyle, may also predispose to sciatica and also diabetes mellitus. The prognosis of sciatica is good, with full recovery in most of cases. So in general, what causes lumbosacral plexopathy? The first is diabetic plexopathy, or what's called diabetic amyotrophy, or the new name diabetic lumbosacral radiculoplexus neuropathy. It's a painful condition affecting lumbar roots and plexus, and hence the name radiculoplexopathy over the upper thigh or buttock. It's mostly unilateral in diabetic patient with type 2 diabetes, presented with peripheral neuropathy also, and hence the name radiculoplexus neuropathy. There is weakness progress over the femoral and obturator nerve, and wasting of the anterior and medial thigh compartment, and may involve the peroneal nerve also. The patient complain of weight loss. Sensory loss is less often with absent patellar reflex. The nerve conduction study will show picture of patchy axonal affection in the form of reduced CMAP and SNAP. But as it is a patchy axonal affection, sensory nerve action potential may be spared, and gives a picture more likely radiculopathy rather than plexopathy. And EMG also will give a picture of axonal affection with signs of denervation and re-innervation. Paraspinal muscles is usually involved also. Recovery occur, but maybe prolonged and last and takes years to recover, and recovery also may be incomplete in some patients. Neoplastic plexopathy, like pelvic tumor of organs like colorectal carcinoma, uterine carcinoma, ovarian, prostatic carcinoma, may cause local invasion of the plexus. Metastasis from other organs like breast cancer, lung, and so on. Also, neurofibromatosis can involve any part of the plexus. The patient presented with unilateral pain with progressive lower motor neuron signs and proximal weakness. Nerve conduction study will show evidence of axonal affection in the form of small amplitude, CMAP, and SNAP. EMG also will show signs of denervation and re-innervation. Imaging of the tumor will help us in diagnosing such condition. The hemorrhagic plexopathy, it's the most common complication of usage of anticoagulants medication. Usually, the hemorrhage occur in the retroperitoneal region and can compress the plexus through the iliac or psoas muscles. Expanding hematoma of iliopsoas muscle can compress over the femoral nerve through its course from its origin to the inguinal ligament. It's presented mainly with pain in the groin and may radiate to the anteromedial thigh and medial leg, with weakness of the quadriceps and adductor muscles of the thigh if the obturator nerve is involved, with loss of knee reflex. Postpartum plexopathy, it's due to compression of the fetal head against the lumbosacral plexus, especially the lumbosacral trunk as it leaves the pelvic rim. In this area, it's exposed and not protected by psoas muscle and near the sacroiliac joint, and could be compressed at this site. Also, the superior gluteal nerve originates near this site and can be compressed. The fibers contribute to the peroneal part of the sciatic nerve, lies posteriorly against the bone and more vulnerable to compression than the tibial fibers. Women presented with a foot drop immediately or few days after obstructed labor, especially if the fetal head was large in a small mother, with weakness of knee flexors, hip extensors in addition. It has a good prognosis because it's demyelinating in nature and good recovery, and many cases may pass unnoticed even postpartum. Radiation-induced plexopathy, patient presented with slowly progressive bilateral lower limb weakness affecting distal more, with numbness and paresthesia less frequently. Pain presented lately. It takes months to years to develop according to the dose and intensity of the radiation used. It's usually accompanied with gynecological and testicular cancer. The EMG, as our professor mentioned in the previous study, showing myochemic discharges, which is pathognomonic for radiation-induced plexopathy. Iatrogenic plexopathy occurred during surgery, like in prostatic resection, in gynecological surgery, like in hysterectomy, or during obstructed labor by using forceps, and orthopedic surgery during total hip replacement, or anesthetic, especially with epidural anesthesia, which may cause retroperitoneal hemorrhage. The mechanism is by either direct compression over the plexus, traction, or vascular insult to the plexus. The femoral and obturator nerve are more affected. Then comes the lumbosacral trunk, lateral cutaneous nerve of thigh, and sciatic nerve. Traumatic plexopathy, the plexus is situated deep in the pelvis and is protected by the bone of the pelvis. So it's relatively shielded from direct injury. Trauma accounts for only a small percentage of the causes of lumbosacral plexopathies. Most are due to penetrating trauma, like in gunshot or puncture wounds, or the most famous is high velocity injuries with fracture of the hip and dislocation, as we mentioned before. The important part in our lecture is electrophysiological protocol for lumbosacral plexopathy. As was mentioned before, we must take history from the patient, how the condition started, when, and what's the course of progression, followed by a clinical examination to determine which part of the plexus is affected. Is it upper lumbar, is it lower sacral, or band plexopathy, or peripheral nerve affection, and so on. Then we will do a motor and sensory nerve conduction study and EMG examination. So what is the protocol of nerve conduction study? If we suspect upper lumbar plexopathy, we will do femoral, saphenous, and lateral cutaneous nerve of the thigh if it is meralgia paresthetica. As I mentioned before, the three nerves is technically difficult, so it's not routinely done in every patient. We do it when we suspect upper lumbar plexus or affection of femoral nerve or lateral cutaneous nerve of thigh, for example. Femoral nerve, it's deep, and it's annoying for the patient to do stimulation of the femoral nerve and need to be compared to the other side. Saphenous nerve also, as we mentioned, technically difficult and may be absent in normal old patient. And lateral cutaneous nerve of thigh, usually in obese patients especially, will be absent. So it will add no additional information if it's absent bilaterally. So if the lower sacral plexus is suspected, we will do our routine nerve conduction study, which consists of peroneal, tibial, CMAP, and for sensory conduction, we will do a superficial peroneal and sural, and of course, F waves and H reflex if S1 or sciatic nerve is suspected. Peroneal nerve compound muscle action potential, we record from extensor digitorum brevis and stimulate at the ankle and below fibular neck and above fibular neck at the popliteal fossa. We are seeking for entrapment or injury of the peroneal nerve around the fibular neck, which can cause foot drop and be confused with sciatic nerve affection or plexopathy. We will do F wave and compare to the other side. Posterior tibial nerve also motor conduction, recording from the abductor hallucis and stimulating at the ankle and popliteal fossa. And compared to the other side, we will do F wave from tibial nerve and compare it to the other side. For the superficial peroneal nerve also, we will do it and compare to the other side, and the sural also will be compared to the other side. Sensory nerve conduction study can differentiate between plexopathy and radiculopathy. As my professor, Dr. Ann, mentioned in the previous lecture, if the lesion affecting distal to the dorsal root ganglia, so the snap will be affected. But if the lesion is proximal to the dorsal root ganglia, the snap will be preserved. So if it's preserved, it's more likely it's radiculopathy. But snap, our sense nerve action potential, can differentiate between plexopathy and mononeuropathy and peripheral neuropathy. Why? Because all these pathologies are distal to the dorsal root ganglia and the sensory nerve action potential will be affected. So what's the importance of sensory nerve action potential done in routine? Superficial peroneal and sural nerve. For the superficial peroneal conduction study, we record midway between the lateral malleolus and the tibialis anterior tendon and stimulate at the lateral cuff about 14 centimeters above the recording site. It will be abnormal in lesion affecting peroneal nerve, sciatic nerve, or lumbosacral plexus. And for the sural nerve, we record behind the lateral malleolus and stimulate at the posterolateral site of cuff, 14 centimeters also above the recording site. And it will be abnormal in lesion of the tibial, sciatic, or lumbosacral plexus. Both nerves, we use 14 centimeter distance, but the distance may vary between individuals according to the length of the limb. What's the protocol for EMG examination in cases of lumbosacral plexus? At least two innervated peroneal muscle innervated by the peroneal nerve, like tibialis anterior, peronei, extensor digitorum brevis. At least two muscles innervated by tibial nerve, like posterior tibial, tibialis posterior, tibialis posterior or medial gastrocnemius. One sciatic innervated muscle, like biceps femoris, one femoral innervated muscle, like vastus medialis, one obturator innervated muscle, like adductor longus. We will examine gluteus medius and gluteus maximus to ensure that superior and inferior gluteal nerve is normal. And we will examine paraspinal muscles according to the level suspected. So what is the finding of our routine electrophysiological findings in lumbosacral plexopathy? We divided into two parts, upper lumbar plexopathy and lower lumbar lumbosacral plexopathy. If it is upper lumbar plexopathy, so the peroneal and tibial CMAP will be normal. Also the sural and superficial snap will be normal. And F wave and H reflex also will be normal. So what is the abnormality? It will be in the femoral nerve conduction, saphenous nerve conduction, and the EMG will show abnormalities in the muscle supply by the femoral nerve and obturator if it is involved. And what's the finding if the case is lower lumbosacral plexopathy? The peroneal and tibial will be abnormal. F wave and H reflex will be affected also. And sural superficial peroneal will be affected, and EMG abnormalities will be affecting peroneal innervated muscles, tibial innervated muscles, sciatic innervated muscles, and gluteus medius and maximus muscle. But the femoral nerve and the saphenous and obturator nerve will be normal. So nerve conduction alone can differentiate plexopathy from neuropathy, but EMG can differentiate between plexopathy and neuropathy. For example, if the case is sciatic neuropathy versus lower lumbosacral plexopathy, we can do gluteus maximus or medius muscle EMG examination. If it is affected, so the pathology will be above the sciatic nerve, and most probably it's in the plexus level, lower lumbosacral plexus. But if it is only sciatic neuropathy, the glutei will be spared. Also, EMG can differentiate between femoral neuropathy and upper lumbar plexopathy by doing the obturator innervated muscles like adductors of the thigh. If it is affected, so it's not femoral neuropathy, it's beyond the femoral nerve. Most probably it is due to upper lumbar plexopathy. It's mostly often it's difficult for the electrophysiologist to localize the level of injury at the plexus level, as the symptoms of the patient may be vague and inconclusive. Also, there is similarity in the presentation between plexopathy, radiculopathy, and sometimes peripheral neuropathy also. So it's often difficult to localize the site of lesion. But the electrophysiological test rule is to confirm and to localize the level of lesion and to assess the severity of the injury and exclude other coexisting neurologic injury. But unfortunately, there is limitation of electrophysiological studies. Lumbosacral plexopathy usually presented as a unilateral pattern, but sometimes it is bilateral. So it's difficult to differentiate between bilateral lumbosacral plexopathy and polyneuropathy, as both conditions will cause abnormalities in the nerve conduction study in the peroneal and tibial. Both conditions will show abnormality on EMG, especially examining the distal leg muscles. Both conditions, the EMG of the paraspinal will be normal. The examination of the proximal hip muscle will be of help in differentiating between both, as it will be abnormal in plexopathy and not in polyneuropathy. Also, by doing nerve conduction of the upper limb, if it is abnormal, so it will help us in diagnosing polyneuropathy, and it's not only plexopathy. The second limitation is that normal paraspinal muscles doesn't exclude radiculopathy, as up to 50% of radiculopathic patients showing normal EMG of the paraspinal. The cause is due to maybe fascicular sparing of some fibers, and so the paraspinal muscles may spare. Difficult examination of the lumbar paraspinal due to poor relaxation, and so we will miss signs of denervation. As the denervation occurs first in the paraspinal, also the reinnervation occurs first in the paraspinal. So if the reinnervation is complete, we couldn't differentiate between motor unit potentials of complete reinnervation and normal motor unit potentials. Sensor nerve action potential may be of help as it will be affected in plexopathy, but not affected in radiculopathy. The third limitation is in acute lesion. In acute lesion, the nerve conduction study and EMG will be normal, as there is no time passed for Wallerian degeneration to occur. So we have to wait 2 to 3 weeks and give time for Wallerian degeneration to occur and to pick abnormalities in our test. So the take-home messages that lateral cutaneous nerve of thigh, saphenous nerve are technically difficult to obtain, especially in obese and old patients. And thus absent responses doesn't conclude any pathology. Normal paraspinal EMG doesn't exclude radiculopathy. Abnormal paraspinal muscles EMG in the presence of previous surgery of the spine doesn't mean a new lesion, as abnormalities of the paraspinal muscles in EMG may last 4 years. If motor unit potentials are equivocal or borderline compared to the other unaffected side, in diabetic patient presented with peripheral neuropathy and polyradiculopathy, it's very difficult to conclude plexopathy by electrophysiological studies. And in some rare cases of L5 radiculopathy, the superficial perineal snap may be abnormal. It's unknown, it's not totally understood what is the cause, but it's maybe due to that dorsal root ganglia of L5 is located very proximal to the intervertebral foramen. So compression by herniated disc, for example, will be distal to the dorsal root ganglia or postganglionic and cause a sensory nerve action potential abnormality. These are some suggested reading for whom are interested to read more about the subject. If you want to take a screenshot for the suggested reading, and thank you for your attention.